Hello, my name is Keith Stewart. I'm a hematologist at the Mayo Clinic in Arizona. I'm here at the ASH meeting in San Francisco where we have presented the results of the ASPIRE Phase 3 clinical trial, which compared Carfilzomib, Lenalidomide and Dexamethasone versus the reference treatment Lenalidomide and Dexamethasone in patients with relapsed multiple myeloma. This Phase 3 clinical trial sought to improve therapy for patients at time of relapse. It compared a reference treatment, Revlimid with low-dose dexamethasone, with the experimental arm, which included the proteasome inhibitor Carfilzomib. The study population were patients who had 1 to 3 prior relapses. They had to have normal renal function, they could not be refractory to prior use of Velcade, and they could not be refractory to Revlimid if it was their last treatment. This was a Phase 3 randomized trial that enrolled 792 patients in 20 countries and 90 sites. The primary endpoint of the study was progression-free survival, the time patients had their disease under control. The primary endpoint of the study was met. There was an unprecedented progression-free survival for the 3-drug regimen of Carfilzomib, Revlimid and Dexamethasone of 26.3 months, which was 8.7 months better than the control, Revlimid and Dexamethasone alone. In secondary endpoints, we examined response rate. Response rate was significantly higher with the KRD regimen. Also, 3 times as many patients entered a complete remission. There was a trend towards overall survival, and very importantly, patients reported a better health-related quality of life while taking the 3 drugs as opposed to the control arm of 2 drugs. Toxicities were also examined carefully to see if the addition of a 3rd drug increased toxicity rates. In fact, patients stayed on the 3 drugs much longer than they stayed on 2 drugs, 88 versus 55 weeks. Despite this, more patients actually came off the treatment on the control arm than did on the experimental arm of KRD. There were equal numbers of severe toxicities in both arms of the trial, and there was no signal with the addition of Carfilzomib that was new. In fact, the toxicities reported for Carfilzomib were generally the same or lower than been reported in studies in more heavily pretreated patients. In summary, the results of this trial show 4 important things. First, adding Carfilzomib to Revlimid and Dexamethasone at relapse improves progression-free survival, it deepens response, it improves quality of life, and it does so without adding substantial toxicity. Because of these results, we now think that Carfilzomib, Revlimid and Dexamethasone in combination should be the standard of care for patients with myeloma at first relapse and beyond.